You know, when you're out in the field, every single sign, every symptom, it's like a piece of a puzzle. But let's be real, some pieces are way more important than others. Today we're talking about aphasia, and this isn't just another symptom. This is a direct signal, a high-priority message straight from the brain's cortex.
Okay, let's get the single most important thing straight right out of the gate. Aphasia is not slurred speech. This has nothing to do with the muscles of the mouth or the tongue. Confusing the two is probably the biggest pitfall you can run into, so we're going to clear that up right now.
So if it's not a muscle problem, what is it? Well, it's a critical signal coming directly from the brain, a signal that can literally change everything about how you manage your patient. So the real question is, when things get chaotic, are you ready to spot it? By the time we're done here, the answer is going to be a definite yes.
Okay, so to be able to spot it, first we have to know exactly what we're looking for. So what is aphasia, really? Well, it's a problem that starts and ends right inside the brain itself.
Let's really break this definition down. Aphasia is a cortical language impairment. That word cortical is the key here. It tells us the problem is in the cortex, the brain's main command center. It's usually caused by an injury, like a stroke, to the part of the brain that handles language, which for most people is the left side. And notice, it affects the entire system, not just talking, but understanding and processing language too.
And that brings us to this absolutely crucial distinction. You have to separate aphasia from its common mimic, dysarthria. Here's the easiest way to think about it. With aphasia, the brain's wiring is damaged. The language software is corrupted. But with dysarthria, the software is totally fine. The problem is that the speakers are broken. It's a physical muscle issue. Getting this right in the field is a game changer.
Okay, so that's the textbook definition. Now let's get practical. How does this actually translate to what you'll see and hear when you're with a patient? What are the dead giveaways to look for in the field?
To keep things simple, you can pretty much boil it down to two main patterns. If you can learn to spot one of these, you are way ahead of the curve.
So first up, you might hear speech that sounds perfectly fluent, but it's complete nonsense. This is sometimes called Wernicke's aphasia. The words flow, the rhythm sounds normal, but it's just a word salad. It doesn't mean anything. On the complete other end of the spectrum, you have non-fluent, really effortful speech, or Broca's aphasia. With this, the patient knows exactly what they want to say, but they struggle like crazy to get the words out. It's halting, it's broken, and you can see the frustration on their face.
And just remember, language is so much more than just speaking. Aphasia can also show up as your patient not understanding your questions, even simple ones, or they might be struggling to find a common word or suddenly not be able to read or write. It's an issue with the entire language package.
So, we can define it and we can spot it. Now for the most important part. Why does any of this matter? What is the real clinical significance of identifying aphasia out there in the field?
This right here is the biggest takeaway of all. Aphasia is a cortical sign. What that means is when you see it, you're looking at direct physical evidence that something is wrong in the brain's cortex. This isn't some vague, fuzzy symptom. It's a specific, localizing sign that points to a really big problem.
And this is so important for three reasons. One, aphasia is a massive red flag for an ischemic stroke, especially a large vessel occlusion, or LVO. That's the big one that needs immediate advanced care. Two, it's a required part of pretty much every pre-hospital stroke scale, like FAST-ED and RACE. You actually can't complete them properly without assessing for it. And three, it's your great differentiator. When you have a patient with an altered mental status, aphasia helps you cut through all the noise of mimics, like low blood sugar or intoxication, and zero in on a potential stroke. So this all leads us to the final big takeaway for your practice. It's all about shifting your perspective. You need to stop seeing this as just another symptom and start recognizing it for what it is, a specific high-yield diagnostic signal.
I want you to really let this sink in. In the field, a patient's language isn't just about how they communicate. It is a direct window into how their cerebral cortex is functioning. It's truly one of the most powerful assessment tools you have, and you don't need any equipment to use it.
So I'll leave you with this question. The next time you're with a patient and they just can't find the words, ask yourself, what have you really found? Because you haven't just found a communication problem. You found a cortical sign. You found a critical clue that can change the entire course of that person's care.